Hello, my name is Edel Murphy. Today I'm going to talk to you about public and patient involvement in research. I work here at NUI Galway and I work in the area of public and patient involvement on a programme called PPI Ignite, which is funded by the Health Research Board. So today we're going to look at what is PPI and what is not PPI. I'll talk you through a few examples and we'll talk briefly about how you might measure the impact of PPI in your research. So we're all familiar with the traditional approach to research. Researchers may be clinicians who have done research throughout their careers, maybe academics who have done likewise, or young career researchers who embark on a full-time career in research. Researchers work in labs, they work in the field, they collect data, very good at collecting health data, good at administering surveys, good at doing interviews, very good at presenting on their research at conferences, and very good at producing papers, reporting their research outcomes, and publishing them in academic journals. Public and patient involvement asks researchers to take a different approach right throughout the research cycle to ask the public or the patient what matters, what research priorities are there, what will work from a research protocol point of view, what language should we use in our information sheets to communicate our research and communicate our research results to the public. These are the questions that we need to ask and have the voice of the public influencing our research. For example, a stroke trial, a phase 3 trial that was testing a new compound drug for improving conditions for people who had survived stroke. Their initial plan had been that the primary outcome would be length of hospital stay post-stroke. But when they spoke to people who had survived stroke and to carers and family members, there was a very strong message that the most important thing to them was not how long they spent in hospital, but how long they lived independently at home after stroke without having to be rehospitalised or put into long-term care. So that flipped the research study. Much easier to measure length of hospital stay. There was a defined end to a person's stay in hospital, more difficult to measure a longer period of time afterwards. So the researchers had to modify their protocol to be influenced by the voice of the public. So what is public and patient involvement? It means that we're talking about research being carried out with or by members of the public rather than to, for or about them. So the idea is that we work with the people we're trying to do research on to plan and do our research and to report on the results. Involve are the UK organisation, the leading organisation in this space on this side of the Atlantic. They are very active in the area. There are a number of different perspectives. No matter how complicated the researcher, how brilliant the researcher, patients and public always offer unique, invaluable insights. This is the Chief Medical Officer in the UK. And recently I had the opportunity to work with a man called Alexis Donnelly, a PPI contributor who lives with progressive MS. And he basically said that inside everybody living with a chronic condition, there is a nugget of research gold. And by working with that person, researchers will find and unearth this nugget of gold, and it will feed into improving the medications, the delivery of health services. Interestingly, Alexis felt and encouraged others that it was his responsibility to get stuck in there and show researchers how to what was important and what to do. So what do we mean by public and patient involvement? We're looking at developing an active equal partnership between the public and patient and researchers at all stages of the research process. It's important that we're trying to proactively involve the PPI contributors as part of the decision-making within research studies. So we want to begin to share decision-making on different aspects of the studies. We're hoping that the voice and perspective of the patient will guide the number of different areas in the research, what we research, how we design our studies, the outcomes we measure, how we conduct our research, how we share the results of our research, and how research influences policy and practice, and many other parts of the research, as you will see from the examples later on. Who do we mean when we say public? Or are we saying patient? Or is it public patient? So basically, what we want is researchers to partner with patients, potential patients, carers, people who use health and social care services, as well as people from organisations that represent those who use the services. So it can be anybody and everybody. Many different terms are used to refer to people who work in an involvement way. Public, patient, a lay person, consumer, citizen, PPI contributor, PPI member. It doesn't matter what we call them, so long as we work and build an equal relationship with them. PPI is best described as being a spectrum of involvement. So this is an example. At the bottom of our triangle here, we have no involvement, the traditional way, where we just recruit participants, collect data, do our analysis, and report on our studies. There's some emphasis on communicating the results of our research to the public, and we're very good at communicating the fact that we want people to take part. So that is communicating outwards. So really we want to move above that to get into the involvement space. So moving up the spectrum from informing people about our research to consulting with them throughout the research process, and then to increasing that level of involvement so they begin to jointly plan with maybe a defined role or a level of decision making, and ultimately to work in partnership where there is joint decision making on all aspects of the study, with patients and public bringing their lived experience and their public view, researchers bringing their expertise, clinicians bringing their expertise, and joint decisions happening based on the combined input. And ultimately get possibly to a situation where the members of the public community initiates research and leads the study and are in full control of it, including analysing the data, with the researchers providing the skills to do the research. So we're trying to move up the spectrum of involvement. There is no right place to be on the spectrum, and we'll have to think about what's appropriate for the research you're doing, and also we have to be pragmatic. There are many other frameworks by which you can describe participation. A lot of them are based on Arnstein's ladder of citizen participation dating from the 1960s. Here's a simple example of how we might begin to do some PPI. In all of our studies, there will be patient information materials given to whoever we want to include our participants in the study, an information leaflet and a consent form. So at a most basic level of involvement, the research will decide the format of the information leaflet. It's A4, it's got 3 or 4 pages, and maybe decide we'll have an ad that we'll put in the local hospital foyer, and they will draft the content. Then present it to PPI contributors and ask them to review it and advise on changes. The researchers go off, decide what they'll take on board, finalise the information sheet and use it. So that's a little bit of involvement, better than no involvement. Improvement on that, where the researchers decide the format, they go and talk to PPI contributors. They say, if we were to recruit people like you into our study, what are the key pieces of information that you would like to see? What's less important? What would you need to know? And they go away, the researchers go away, draft it, come back, present it to the contributors, who again discuss it, maybe advise on further changes. Researchers go away, make the decisions on what they'll take on board, finalise it and use it. And then maybe the gold standard in this small component of work would be where the researchers and the PPI contributors work together right from the start. The PPI contributors have a major input into deciding the format, identifying the priority information required, and possibly even designing and writing the information leaflets. It doesn't really matter who actually writes them. It's around getting the language right and getting the format and getting the key messages, what matters. And then I know in the clinical trial space in particular, because of regulations and ethical requirements, there are pieces of information that you have to put in. Well, your PPI contributors can help you to shape the information sheet so that the material that matters most to the potential audience is easily found and easily visible. And then the researchers say, well, look, we have to add in X, Y, and Z, so you can add in them in an appropriate place and critically in an appropriate language that the audience are going to understand. The researchers may review what the PPI people have written or vice versa, and all will work together, revise, finalise and use. So I think you'll get there, the different levels of involvement, and it's about developing both researchers' ability to work with PPI contributors and PPI contributors' ability to contribute. Researchers often feel the only contribution a PPI group can do is to take a look at their information sheet. It's not the best use of your PPI group, but this is an example where you can increase that involvement as you go along. So what is not PPI? Well, recruitment of study participants isn't PPI. That's participation. So when you recruit people into your study, they sign consent, you take data from them, you collect data from them, that is not PPI, that's participation. When you tell people about your research, that is not involvement, that is engagement. You may create awareness by having information evenings about work you're doing. You may allow some Q&A, but all the decision making is by the researchers, and that is not involvement. You may go back and report on your research results, that's still engagement. The conversation is all going one way. Qualitative research is not public patient involvement. If you're doing interviews, yes, you're getting the voice of your target audience and you're including that into your research study, but that is not involvement. The researcher needs to work with your PPI group to plan out your qualitative research, to help you structure your interview schedules. Focus groups, where you gather people and consent them into your study, and again a researcher comes up with the agenda and so on. Focus groups is a methodology of gathering qualitative data. You use some similar methodologies in working with your PPI contributors, but there is a distinct difference. That reference there, Dory et al., is very good on explaining one from the other. Evaluating processes is not PPI, and it's really important that PPI isn't tokenistic. Bit of a tendency to say we'll put a PPI contributor on our steering committee or we'll write them into our grant application. That's tokenism, and we want to avoid that. Why do PPI? Why involve the patient at all? There are a number of different reasons for doing it. You can say a lot of funding is public and a lot of research is publicly funded, and therefore the public have a right to have a say in how that money is used. You can say it improves the quality of your research. There's many different arguments. It's good for improving transparency of research. The bottom line to me is you're drawing on the lived experience of the patient, the carer, the family member, the teenager, the person with a particular condition, whatever is your target audience. And really, they are the people who know what the conditions that you're trying to research on. And therein lies the main reason in my head, or the main reason why this is so important. Okay, so let's look at some examples. So the first one I'm going to take here is one done here in NUI Galway by Professor Sean Deneen, who's the PI on the PPI Ignite programme that I work on. Sean is a diabetes doctor, consultant in the hospital. He's an academic and a researcher. He deals a lot with young adults living with type 1 diabetes. Very hard to maintain their care consistently from about 18 to 25 years of age. It's great while they're in school, while they're at home, but then their life moves into a whole other area, college, work, living away from home, and they really rebel against having to live with this chronic condition. So Sean is trying to reimagine diabetes care for people in this age group, but he's not doing it on his own, he's not doing it with researchers. He has set up a young panel of people living with type 1 diabetes, and he has worked with them building their PPI capacity and building the researchers' capacity to understand what PPI is over the last 3 or 4 years. And they're now piloting an intervention which has been put together with the young panel guiding the research plans and qualitative research, quantitative research being done to come up with an intervention, a complex intervention that's now about to be piloted. This is a really good example. I picked this example because of the module you're currently following. The Nottingham Biobank have a really, really good example of involvement. From their website, they say that the PPI aim was to ensure that the processes and services of the biobank were designed with patients and with the public, for patients and the public. They wanted to develop more sensitive and user-friendly approaches to patients who may get involved in the consenting process. And they wanted greater opportunities to share biobank news with patients and use media and so on. So the last one is probably a little bit more outreach, but the first two we would certainly consider as being involvement. But they went further than that. They recruited people with lived experience of the diseases that the biobank is researching to go on this journey with them. They trained a group of PPI contributors on the whole biobanking process to understand everything that's involved in it, including the ethical challenges, including the procedural challenges and so on. And they looked at their whole consent package and the consent materials, the information sheets. But they then developed a consent training package, and the PPI contributors were involved in developing that. And then between the two of them, they decided that they would train some of their contributors to actually lead the process of consent in one particular area. So they trained 5 PPI contributors to become consenters, and these 5 people said, yes, we will go to clinics, I don't know, twice a month or 3 times a month. They gave a commitment how much they do, and they have gone out and been the first point of contact to recruit patients to give samples for the biobank. There's excellent feedback from both patient and PPI contributors. The rate of consent to submit samples has increased. This isn't the purpose of PPI, but it often is an end product of the PPI or a positive impact that comes out of it. And it's a good example of embedding the patient perspective at the core of the biobanking process. So there are many other places in the research cycle where the patient voice should be included and can influence what's happening. Setting research priorities right at the very start. Really important role in systematic reviews, where you have your patient voice in setting your review outcomes, in interpreting your review data, and in helping you write conclusions from what you have found in the research. In disseminating research, but again, it has to be with contributors that are being part of your research process. There's a danger of it being tokenistic otherwise. And again, your PPI contributors who have worked with you can play an important role in influencing policy change and, as we mentioned, helping with recruitment. So how do we know if this works? How do we know if PPI makes a difference? It's not easy to measure. There are a number of different approaches, some theoretical frameworks that are quite complicated, but it is an area that requires some attention. So there are a number of different places and aspects you can think about measuring. You can measure any changes to the conduct to your protocol. You can look at where there are changes to the research outcomes that were influenced by your PPI contributors. What's the impact on the researchers? You can do some qualitative research, some quantitative research on that. A lot of work, or some work, has been done on looking at the impact of being a PPI contributor on the participants, the PPI contributors, the lay contributors, where they actually become research participants and qualitative interviews are conducted on them. But it's about their work as a PPI contributor. And you can look at changes that have occurred to either health service policy or delivery through the influence of your PPI contributors. As I say, there are some frameworks. The PIAF is one of these, but it is something that a lot more work is required. So I'll leave you here with some useful references and resources. There are a number of different theoretical frameworks, as I mentioned, and some references to it there, and references on measuring the impact. And finally, to say to you that I work, as mentioned at the start, on the PPI Ignite at NUI Galway programme, nuigalway.ie/PPI, and we're also active on Twitter, and we will run and are running training events in this area for both members of the public and for researchers. So we really are keen to broaden out knowledge of, practice of, involvement in involvement across the university. So thank you very much.